graduate in Pathology Season 3. Today's talk is on the head and neck pathology. Today, Dr. Katha Kante Ravade is the faculty, and he is going to give talk on pathology, grossing, and standard reporting of head and neck. Today, chairperson is Dr. Anita Borges, ma'am. She is a consultant pathologist, Center for Oncopathology, Tata Trust, Mumbai. And today's faculty is Dr. Katha Kante Ravade. She is Associate Professor in Department of Pathology, TMH, Mumbai. Today's moderator is myself, Dr. Nishi, and Dr. Lopa Mudra Kakoti. She is from Dr. B. Badwa Cancer Institute, Guwahati, Assam. And today's webinar host is Dr. Anita Borges, ma'am, and Dr. Sumit Gujral, sir. These are few reminders. In case of any connection interruption, low or no sound, video freezing, please leave the meeting and rejoin with the same link. Please do not send any request for a notation to the presenter. These are few disclaimers. These are few more disclaimers. Few upcoming talks are on 30th November. There is a slide seminar over the surgical pathology, head and neck. One that is over the oral cavity, and the faculty is Dr. Munita Bal, ma'am. And the next one is on 5th December. Topic is approach to salivary gland neoplasm, and faculty is Dr. Anita Morgis, ma'am. Now over to Dr. Katha, ma'am. Now I'm stopping the sharing of PPT.
Yeah, I'll share my screen. I've just shared my screen. Is it visible full screen?
Yes, ma'am.
Okay. Good evening, everybody. I will be starting with the first chapter of head neck pathology. So I will be taking a very basic class on the basic anatomy of major head neck sites, their grossing and standard reporting. So let us start with it. Like I said, my outline will be to explain to you the basic anatomy of the major head neck sites, their grossing and standard reporting. Okay. So head neck cancers are the commonest cancers in India, oral cavity cancers being them. There are multiple anatomic sites in the head neck region because of their complex anatomy and association of with the vital organs. Their diagnosis in time is prudent, and treatment decision because of this requires a multidisciplinary approach or a disease management group. So by multidisciplinary approach, I mean a team of surgical oncologists, medical oncologists, radiation oncologists, pathologist and radiologist help in assessing the patient, in determining what histologic type the tumor is, the extent of the tumor, and which treatment would be ideal for this patient. The other disciplines that also help in treating this patient include a dentist, physiotherapist, the rehabilitation team after the surgery, palliative team in case the tumor is very extensive and cannot be resected, and a speech therapist, especially for laryngeal tumor. So the treatment options that are available for head neck cancers are surgery, radiation, and chemotherapy. Chemotherapy can be given before the surgery, that is neoadjuvant chemotherapy, or it may be given as adjuvant chemotherapy. In extensive tumors, even targeted therapy is used. The different factors that help in determining the treatment are tumor factors, which is the histologic type, grade, the extent of the tumor, which determines the stage, nodal status, and distant metastasis. Patient factors is the patient's general condition. So accurate risk stratification is necessary to decide the modality of treatment, whether it will be a single modality treatment or multiple modalities need to be used. There are different prognostic factors which determine which patient will require adjuvant treatment. So these are any parameter that is available at the time of surgery that correlates with disease-free or overall survival in the absence of adjuvant systemic therapy. That means it helps to identify a subset of cancer patients that would recur if there was no adjuvant systemic therapy that was given to this patient. Therefore, it identifies the patients who would benefit from adjuvant therapy. So such prognostic factors are clinical factors, which are clinical stage, localization, and performance status of the patient, and also many histopathological factors which help in evaluating whether this patient will require an adjuvant therapy or will benefit from adjuvant therapy or not. So it is tumor size and the extent of the tumor, including the involvement of adjacent organs, the type of the tumor, that is a histologic type, the grade of the tumor, depth of invasion of the tumor in oral cavity tumors, invasive front, which is the pattern of invasion, worst as well as predominant pattern of invasion, again has prognostic significance in oral cavity tumors, vascular invasion or perineural invasion, the resection margins, whether they are closed, they are positive, or they show dysplasia at the margins. The nodal status of the patient's number of nodes positive, whether these nodes show extranodal extension or not, and also some molecular factors. But molecular factors have very limited studies have been done for molecular factors and have not been validated for further prognostication. So firstly, anatomy of oral cavity. So oral cavity consists of upper alveolus, lower alveolus, the tongue, the upper and the lower lip, the buccal mucosa, gingival-buccal sulcus, which is the lower gingival-buccal sulcus and the upper gingival-buccal sulcus, and the hard palate. Also, there is retromolar trigone, which is present behind the second, triangular space present behind the second, behind the third molar, last molar on the mandible, and the floor of mouth. This is the palate. So palatal tumors are also included in the oral cavity and the upper alveolus. Sinonasal tracts, the anatomical structures are the nasal cavity, paranasal sinuses, that is the frontal sinus, ethmoid sinus, maxillary sinus, sphenoid sinus, and the sphenoid sinus. So this is a coronal view showing all the sinuses. So the maxillary sinuses are these pyramidal shaped sinuses. These pyramidal shaped sinuses, which are facing medially along the lateral nasal wall and the apex pointing towards the zygoma. Their floor is formed by the hard palate and roof is formed by the base of the floor of the orbit. So there are two maxillary sinuses, one on either side. The frontal sinuses, these sinuses are anterior. They are located in the frontal bone. Ethmoidal sinuses are multiple number of air cells which are present in the upper nasal cavity between the two orbit. The sphenoid sinuses are located posteriorly in the body of the sphenoid bone. So the sagittal view showing the frontal sinus. These are the multiple ethmoid air cells, the sphenoid sinus in the sphenoid bone, and the maxillary sinus. So these are sagittal views. First one on the left showing the nasal septum, which is formed by the greater alar cartilage, the nasal bone, perpendicular plate, and the vomer. The frontal sinus and the sphenoid sinus can be seen here. This is the, on the right side is the lateral wall of the nose, which shows the turbinate, superior, middle, and the inferior turbinate. They are attached to the anterior aspect and are free on the posterior aspect. The maxilla is formed by the alveolar process. It has alveolar process of maxilla, the frontal process of maxilla, and laterally the zygomatic process of maxilla. And on the floor is the palatine process of maxilla, which is seen in this sagittal view. Again, one more picture showing the relation of the maxillary sinus. In front is the nasal cavity, and just on top of it is the orbit above the maxillary sinus. So the maxillary sinus is divided into two parts, the suprastructural part and the infrastructural part. The division is made by an imaginary Ongren's line, which extends from the medial canthus of the eye up to the angle of mandible. So the tumors which are on the inferior aspect of this line are treated by infrastructural maxillectomy. The tumors which are located and limited to the superior aspect are treated by a suprastructural maxillectomy. The suprastructural maxillectomy, like you saw in the previous slide, have worse prognosis because of their location. These can easily spread to the base of the skull, the orbit, and the infratemporal fossa. And also these tumors have a late presentation. Next, we move on to the anatomy of the larynx. So larynx has supraglottis, is divided into supraglottis, glottis, and the subglottis. So the supraglottis is the part which is from the epiglottis up to the ventricular fold or the false vocal cord. This consists of epiglottis, aryepiglottic fold, the arytenoids and the false vocal cords, and also the ventricles. The glottis is composed of the true vocal cords, the anterior and the posterior commissure, and the subglottis is the portion below the glottis up to the inferior margin of the cricoid cartilage. Sorry, this is the epiglottis. These are the true vocal cords. This is the subglottis. This is the thyroid cartilage which is present, and this is the cricoid cartilage. So supraglottis has a rich lymphatic network, hence there is no more nodal spread. Glottis has more local spread, and subglottis also spreads to the adjacent structures first and then to the nodes. There are two spaces called the paraglottic space and the preglottic space. These are potential spaces which are composed of adipose tissue and are traversed by lymphatics and blood vessels. The significance of these places is this upstages the tumor to T3. Involvement of these spaces upstages the tumor to T3. So this is first, the picture on the left hand side is the coronal view showing the epiglottis, the thyroid cartilage laterally, and the space which is shown by yellow, the fat, is the paraglottic space. So it is bounded by hyoepiglottic membrane, the thyrohyoid membrane, thyroid cartilage, and the conus elasticus. This space is known as the paraglottic space. The next space is seen in the sagittal view, which is the pre-epiglottic space. It is a triangular space present anteriorly to the epiglottis. This is limited by the hyoepiglottic membrane superiorly, the thyrohyoid cartilage and the thyrohyoid membrane, and the hyoid cartilage inferiorly. So we move on to grossing of the specimen. So whenever we receive a specimen for grossing, along with it, we receive a requisition form, which contains the demographic data of the patient, that is the name of the patient, age of the patient, sex of the patient, the ward or the hospital it is sent from, with the details of the operating surgeon and any contact details of the surgeon as well. So that we can contact in case of any discrepancy. It has the clinical details of the specimen. There is a mention of any prior chemotherapy or radiation that was given to this patient. The requisition form must contain list of all the specimen that are sent to the pathology lab, including the frozen section specimen, and the orientation must be provided by the surgeon. Once the specimen is received, we have to document the type of specimen received, whether it was received in formalin or in fresh state, whether the laterality of the specimen is mentioned, and to check if the laterality mentioned is correct or not. Then you identify you see the details of the tumor, whether any tumor is visible or not, the number of tumor foci seen, the size of the tumor, site of the tumor, extent of the tumor. Then we need to document the margins, the adjacent tissue that is seen adjacent to the tumor, whether it is showing any leukoplakia or erythroplakia. Lymph nodes lymph nodes sent with the main specimen, whether these nodes show, whether these the level of nodes that are given, each level of node should be grossed separately. We should mention the number of nodes that are sampled, whether they are grossly metastatic or not. And then lastly, the grossing paper should consist of a section key. The type of oral cavity resection specimen that we receive, the simplest one is the tongue, which we receive wide excision, or a glossectomy. It can be a hemiglossectomy, anterior two-third glossectomy, near total glossectomy, or total glossectomy specimen. For buccal mucosa, lip, and angle of mouth, we may receive wide excision of these lesions or composite resections. Composite resection is when more than one subsite of the head neck region is removed. Oral cavity resection specimen in addition also consists of mandibulectomy, so hemimandibulectomy or extended hemimandibulectomy. Segmental mandibulectomy, which includes middle one-third mandibulectomy and posterior segmental mandibulectomy, and marginal mandibulectomy. Limited maxillectomy may be received for upper alveolus tumors like upper alveolectomy or a palatectomy specimen. And when upper and lower alveolus both are removed, a bite composite resection may be received. So this is a photograph of a buccal mucosa wide excision specimen. You can see this irregular mucosal irregularity on the surface of the buccal mucosa, and the specimen is oriented with two threads. Another example of wide excision of tongue specimen where the tumor is located on the lateral border of the tongue. The specimen is oriented by a single thread, which is anterior, and the mucosa adjacent to it. So this is again the photograph of the same buccal mucosa specimen. So there are two sutures, maybe one lateral and one anterior. This is the tumor. So we need to identify the tumor. We need to ink all the raw surfaces, the lateral soft tissue margin. These are the mucosal margins. Once you delineate the tumor, the margins would be from that region up to this edge. So this is the anterior margin. So this is the anterior margin. This is the superior margin. This is the inferior margin. And this will be the posterior margin. And on the lateral side, there will be lateral soft tissue margin. These are some more examples of total glossectomy specimen. This is the tongue. There will be a lateral margin on either side, right lateral and left lateral mucosal margin. There will be an antero-inferior margin, which is present at the floor of the mouth, and a posterior mucosal margin. The base will be formed by the lower soft tissue. This is hemiglossectomy. So there will be a medial mucosal margin, a lateral mucosal margin, anteriorly the anterior mucosal margin and the posterior mucosal margin. So this medial soft tissue on this side would be the base. This same specimen, tumor, these four margins, medial, posterior, lateral, and anterior. And on this side would be the base. These are the type of mandibulectomies. So this is marginal mandibulectomy where the full thickness of mandible is not removed. Some part of the mandible is removed. Middle one-third mandibulectomy is a type of segmental mandibulectomy where the middle one-third of full thickness of the mandible is removed. Segmental is any part of the mandible full thickness is removed. And hemimandibulectomy is one side of the mandible, one arch of the mandible is removed. And extended would be anything more than this. This is upper alveolectomy where part of the upper alveolus is removed. So this will have this anterior margin, posterior margin, superior margin, and medial margin. The bony margins would be, this would be posterior bony margin, anterior margin, and on the palate, the superior margin, on the palatal side, the medial palatal margin. This is an example of a hemimandibulectomy where there is a tumor which is seen on the buccal mucosa and the gingival-buccal sulcus. It is also involving the lower alveolus. So this tumor would have again 4 mucosal margins, medial, anterior, and posterior, and there will be just one anterior bony cut margin. As for soft tissue, there will be a lateral soft tissue margin present on the other side. If there is skin, then there will not be any lateral soft tissue margin. We have to document whether the skin is involved or not. And if involved, then whether involved or not, we have to take a section of the skin. And if it is involved, we need to take a closest skin cut margin. This is a specimen, this is a bite composite resection where the tumor is here in the RMT. So this will again have 4 mucosal margins, like this will be the superior mucosal margin, posterior, inferior or superior, inferior, posterior, and the anterior margin. And it will have anterior mandibular cut margin. On the superior aspect, it will have superior bony cut margin and the medial palatal margin. So again, the same. This can also be labeled as superomedial and inferomedial or superior and inferior mucosal margins. For sinonasal tumors, the type of specimens that are received can be endoscopic endonasal resection. Maxillectomy can be limited maxillectomy when 1 or 2 walls are excised. Infrastructural maxillectomy, suprastructural maxillectomy, subtotal maxillectomy, or entire maxilla from floor to the roof is excised. And there can be total maxillectomy with orbital exenteration. Endoscopic nasal resection is a minimally invasive surgery. It is usually used for tumors located in the skull base and for some sinonasal tumors. The tumor is removed either en bloc or piecemeal. The relevant margin and adjacent tissue in these cases are sent separately, and we just need to submit the tumor specimen that is given and the margins that are sent separately. These are some photographs of maxillectomy specimens. So the first one, medial maxillectomy, is where the medial part of the maxilla is removed with the lateral nasal wall, the floor and the part of the maxilla, the medial part of the maxilla. Infrastructural maxillectomy is the lower part of the maxilla. Suprastructural is the upper part of the maxilla is removed, and the alveolar part is left. Subtotal maxillectomy is type of an extended infrastructural maxillectomy where the part in addition to the infrastructural maxillectomy is removed. Sometimes it may contain the floor of the orbit as well. Total maxillectomy is where the total maxilla is removed along with or without orbital exenteration. This is a specimen of infrastructural maxillectomy. This is the tumor which is located on the upper alveolus. So this is the tumor. This is the posterior margin. This is the medial margin. This is the anterior margin. And on this side is the lateral margin. So these were the mucosal margins. The bony margins would be this anterior part, this superior part, and on the medial side, the medial palatal margin. So margins of maxillectomy specimens are mucosal, bony, and other margins if present. If the nasal septum is present, we need to give the nasal septal margins. If optic nerve is included, that is orbital exenteration is done, then an additional optic nerve margin needs to be taken. So mucosal margins include, like we said, medial palatal margin, lateral gingival margin, anterior alveolar margin, and posteriorly also palatal margin. Nasal mucosal margin is taken if included in the specimen. Antral mucosal margin is usually sent separately by the surgeon. Bony margins include the palatal medial margin, the lateral zygomatic part of the bone, that is bony margin, and superior bony margin in cases of upper alveolectomy or infrastructural maxillectomy. Next, we move on to the laryngectomy specimens. So the type of specimens include laser excision, which are done for localized tumors, partial laryngectomy, and near total or total laryngectomy. Near total laryngectomy and total laryngectomy is performed for cancers which are very advanced. Near total laryngectomy consists most part of the larynx except for preservation of one arytenoid and strip of the posterior laryngeal mucosa. Total laryngectomy consists of the entire larynx including the upper tracheal rings. Laser excision and partial laryngectomy are performed for tumors which are of T1, T2 stage. So in for laser excision specimens, the specimen, a very tiny specimen is included. I'm sorry, there is some problem. And the specimen is inked with different inks because the specimen is so tiny. So on the medials, laterally, it is inked purple. On medial side, it is inked green, posteriorly blue, and anteriorly orange. And the specimen is serially sliced and submitted entirely. So this was the specimen which is submitted from the anterior to the posterior aspect. So this is the green medial margin and the orange lateral margin. This is anterior part and posterior part. This is a picture of a total laryngectomy specimen. This is cut open from the posterior aspect. So this is the epiglottis, supraglottic part. This is the glottis. So the tumor here is located in the glottis, and this is the subglottis. In laryngectomy specimen, also all the raw surface, the soft tissue is inked entirely. Another example, a very tiny ulcerated tumor is seen here. Again, opened from the posterior aspect. This is another tumor, which is the epicenter looks like it is in the glottis, but it is extending to the subglottis extensively. So this specimen, the margins would include, this is the posterior margin. This was intact and now it's cut open. So this will be the posterior-inferior margin. On the anterior part of the epiglottis will be the epiglottic margin. This is the left lateral margin at the pyriform sinuses, right and left lateral margin. And inferiorly will be the inferior tracheal margin, which is usually taken shave. All the other margins in head neck are taken as radial margins. So the specimen is cut from superior aspect to inferior aspect serially. And it is arranged like this on your grossing table. And then we need to assess which of the sections are showing the tumor with maximum extent. So this section, this is from the supraglottis part. This is the glottis part and the subglottis part. So here the tumor is extending into the cartilage. Like we can see, it is destroying the cartilage through and through and extending beyond it to the anterior strap muscles, and also now involving the thyroid gland. So this inferior most part will be the inferior tracheal margin. So representative sections need to be taken from the supraglottis, the glottis showing the thyroid cartilage, the subglottis with the cricoid cartilage, and the furthest extent of the tumor. And it can be submitted in grid fashion. So all head neck mucosal margins in head neck are submitted radially. Mucocutaneous margin in rib resections can be submitted shaved unless they are very close. Soft tissue margins and base are also submitted radially. Bony margins are submitted shaved, and the inferior tracheal margin in total laryngectomy is submitted shave. So what I mean by shave and radial margin is If this is the tumor, I am taking a section perpendicular from the tumor to the margin. This is known as the radial margin. So even on microscopy with the ink here, I can measure the margin from the tumor. And shave margin is when the margin is taken parallel to the ink surface. That is a shave margin. So here I cannot measure the distance of the margin from the tumor on microscopy. So after grossing is done, you need to make a have a section key for the reporting pathologist to know where the sections are taken from. So grossing, the specimen should have tumor sections, ideally with the normal mucosa adjacent to it, underlying bone, skin if present, margins, mucosal soft tissue and bony margins, and lymph nodes, and any other specimen that is sent along with this primary tumor. So the protocol for reporting specimens or standard reporting proformas. There are different protocols that are available, which include the protocol for examination of specimen by the College of American Pathologists, the CAP guidelines, or the ICCR, or the Royal College of Pathologists. These are some standard data sets for reporting cancers and are available free on the internet. The staging of cancers is done by the TNM staging, which was developed by the American Joint Committee on Cancer and is used for cancer staging worldwide. It allows uniform communication of the anatomic extent of the disease and thereby aids in the prognosis and management. The current staging for head and neck cancers is provided in the 8th edition of HACC Staging Manual. So to reiterate, the specimen request form should contain demographic data, clinical findings, history of prior chemotherapy or radiation, list of all the specimens sent to pathology lab, and the orientation of the specimen. The standard reporting proforma will include the demographic data and the details of the grossing specimen and section submitted, the core data, and the non-core data. So core data are those elements which are essential for clinical management, staging, and prognosis of the cancer. And non-core elements are those elements which are clinically important, but have not yet been validated or regularly used in the patient management. The additional parameters also may be included for comprehensive report and research purpose or data collection. So the core elements in oral squamous cell carcinoma, which is the commonest cancer of the head neck region, include tumor site, tumor dimension, tumor histologic type, histologic tumor grade, depth of invasion, pattern of invasion, bone invasion, perineural invasion, lymphovascular invasion, margin status, number of lymph nodes involved, and extranodal extension, and pathologic stage of the tumor. There are non-core elements which are expected to be given in the report, which include tumor focality, the tumor, in addition to the largest dimension, the other two dimensions of the tumor, if there is any coexistent pathology, and if any ancillary studies have been done on this specimen. There are other promising parameters that are being evaluated and validated, which include tumor budding, tumor stroma ratio, the lymph node burden, that is the number of nodes involved upon the total number of lymph nodes that are dissected, major and minor ENE. So the maximum tumor size. All the three dimensions should be recorded grossly, including the length, width, and the thickness of the tumor. The maximum dimension is essential to determine the T stage of the tumor. If the microscopic dimension exceeds the gross dimension, then this dimension should be used for PT stage. Tumor extent also needs to be noted. So these are the two dimensions of this tumor, and the third dimension is measured after slicing the tumor serially. Again, this is the largest dimension of the tumor. For depth of invasion, it is this. This is the thickness of the tumor from the uppermost part of the tumor to the lowermost part. So sorry. So for depth of invasion, it is measured microscopically. The we need to understand the difference between tumor thickness and the depth of invasion. Tumor thickness is something which we can assess on gross as well. It is the distance measured from the superficial most part of the tumor to the deepest point of invasion of the tumor. Depth of invasion is assessed on microscopy. It is the distance from the basement membrane of the mucosa to the deepest point of invasion of the tumor. This predicts recurrence and nodal involvement in T1 and T2 tumors. So this is an example of a squamous carcinoma where you see this adjacent basement membrane. So a line is drawn from there and a plumb line from this point to the deepest point of the tumor. So we can see the tumor is still here, but we can see the small tumor islands which are invading even further. So the depth of invasion would be up to this. Another example, a line parallel from the basement membrane of the adjacent mucosa and a plumb line, a line perpendicular down up to the deepest point of the tumor. So for an exophytic tumor, the tumor thickness will be from the uppermost part of the tumor to the deepest point, and the thickness will be from the and the depth of invasion would be from the basement membrane to the deepest point of the tumor. So there will be for proliferative tumors, the depth of invasion may not be much and the thickness may be over 1 centimeter, but the depth of invasion would be less than 5 mm. Again, a very proliferative type of tumor with a thickness which is much more than the depth of invasion. One more example of the same. So the T staging for oral cavity depends on the size of the tumor. So T1 are tumors which are less than 2 centimeters and also less than 5 mm, show less than 5 mm depth of invasion. T2 are tumors which may be less than 2 centimeter, but the depth of invasion changes them from T1 to T2 by if they are more than 5 mm, but less than 10 mm. T3 tumors are more than 4 centimeter tumors or any tumor which shows depth of invasion more than 1 centimeter. And T4 are moderately and very advanced tumors. T4A being tumors which involve the cortical or the medullary bone and the skin. And T4B are advanced tumors which involve the pterygoid plates, skull base, and in case the internal carotid artery. Next core element that is the histologic type. We will here focus mainly on squamous cell carcinoma because it is a common cancer for of the head neck region. So the histologic type and also if it is a variant of squamous carcinoma, it should be documented. So this is the tumor, squamous carcinoma. This is verrucous carcinoma, where you see very proliferative sort of exophytic growth pattern and the infiltrative fronds are broad. So if the section is not taken with the adjacent mucosa, it is very difficult to differentiate between verrucous hyperplasia and verrucous carcinomas. Verrucous lesions lack atypia, and hence a section with the normal adjacent mucosa is essential to document the invasion beneath the adjacent mucosa, thus making it a verrucous carcinoma. So another example of verrucous carcinoma. This is a basaloid squamous cell carcinoma, very basaloid cells with scant cytoplasm, hyperchromatic nuclei. Very focally we may see squamous differentiation. This is a sarcomatoid spindle cell carcinoma. So here the differentials include other spindle cell tumors. This is a mucoepidermoid carcinoma, which is a carcinoma of the salivary glands, but it involves both major and minor salivary glands. So this is partly cystic tumor nodule, which is showing these mucous cells and these squamous and intermediate cells, squamoid and intermediate cells, these clear cells, and lot of mucin in the cystic cavity. This is an adenoid cystic carcinoma showing basaloid cells with this cribriform architecture. So after the histologic type, we grade the tumor, that is the degree of differentiation. The most aggressive grade needs to be noted. Squamous cell carcinomas are graded as well differentiated, moderately differentiated, and poorly differentiated based on their keratinization and nuclear anaplasia. Mucoepidermoid carcinomas are graded as low, intermediate, and high-grade tumors. Adenoid cystic carcinomas are graded as grade 1 to 3 based on the solid areas. Next is the pattern of invasion. Pattern of invasion is seen at the tumor host interface. It was initially described by Brian as pattern 1 to 4, and it was modified by Brandon Gensler as pattern 1 to 5. Pattern of invasion has a proven prognostic value, especially when the worst pattern of invasion is 5. It is significantly associated with local latent recurrence and poorer disease-free survival. It is one of the additional factors that is recommended for clinical care. So this is pattern of invasion 1, which is tumor invasion in broad pushing fronts. Again, broad bands, and the cells broad bands with this lymphocytic infiltrate, sorry. This is pattern 2, which is showing some broad bands, but also this finger-like projections and some stellate tumor islands. This finger-like projections and these islands. Pattern 3 is invasive fronts, shows these tumor islands which have more than 15 cells per island. So predominantly it is showing this pattern 3. Again, pattern 3. Islands containing more than 15 cells. This is pattern 4, which is showing the stranded pattern and small nests which are less than 15 cells. These small islands. Pattern 5 is defined when there is is assigned when there is a tumor satellite nodule of any size which is 1 mm from the main tumor. So this island is away more than 1 mm away from the main tumor. Sorry. The next element is the margin status. So assessment of the margins should be done for all mucosal, soft tissue, and bony cut margins. Margins may vary, and they are submitted in the grossing. They may vary according to the nature of specimen, and some separately sent margins should also be assessed, which are sent by the surgeon. Inking of margin is essential before cutting the specimen. So this tumor, the same buccal mucosa tumor, and this margin here. So mucosal margins, and this is the bony margin, which is taken shave. So on microscopy, we need to see if there is any dysplasia at the margin, if there is any tumor close to the inked margin. If there is tumor that you can see, we should again see if the distance of the margin from the tumor is as mentioned in the gross. If it is close, then it needs to be documented that it is 3 mm away, 4 mm away. If there is tumor at the margin, even that needs to be, so positive margin is tumor at the inked margin. This is a soft tissue margin. You can see skeletal muscle bundles here. So margins need to be given as involved, close, or free. If they are close, the distance from the tumor is documented. Next is perineural invasion and lymphovascular emboli. So perineural invasion predicts aggressive behavior and is associated with poorer outcome. PNI should be mentioned irrespective of the size of the nodes. So PNI involving small as well as large nerves needs to be documented. It may be reported if it is extratumoral or intratumoral, because extratumoral PNI is prognostically more relevant for locoregional recurrence and disease-free survival. Lymphovascular emboli is the presence of tumor within the endothelial line space. It should be differentiated from an retraction artifact. So this is perineural invasion. This is a nerve and the tumor surrounding the nerve. This is a vascular space and an emboli within this vascular space. So LVI. Involvement of bone and skin, the presence and absence of transcortical or medullary bone invasion or skin invasion determines the T stage. So in the presence of this, tumor will become T4A. It upstages the tumor. We need to document whether the tumor is involving the bone or just eroding the bone. If it is involving the bone, we may also document whether it is a transcortical involvement of the bone or involving the medulla. It is not a mandatory element, but documentation may be made. Again, bony invasion. This is tumor involving the skin. We can see the skin here, some pilosebaceous unit here, and tumor is involving the skin. So again, this is T4A. If there is dysplasia which is severe or carcinoma in situ, the presence of this should be documented. And if there is severe dysplasia close to the ink margin, even the distance from such dysplasia needs to be documented. The elements that we saw up till now were mainly for oral squamous cell carcinomas. In addition to those, there are some other parameters which are essential in laryngectomy specimen. These include cartilage involvement. For cartilage involvement, we need to document whether the cartilage involvement is limited to the inner cortex of the cartilage or extending through and through the cartilage. That is full thickness involvement of the cartilage. This will upstage the tumor to T3 from T2. We need to document the involvement of the anterior strap muscles, the pre-epiglottic pad of fat, and the involvement of thyroid gland. So lastly, before I finish, I want to add a cervical lymph node dissection, the grossing of this in short. So there were many changes that were made in the 8th edition of cervical nodal dissection. Main ones are that there was inclusion of extranodal extension in the N categorization for all head neck carcinomas, except EBV and HPV related cancers. And there was an introduction of a separate category for occult primary tumors of head neck with P16 and EBV tumor testing. So these are the lymph node levels. This is level 1A, 1B, submental node, submandibular node. Upper jugular are level 2A, level 2 nodes. Middle jugular are level 3, and level 4 nodes are the lower jugular nodes. The posterior compartment nodes are the level 5 nodes. The anterior compartment nodes are the level 6 nodes. Other nodes include superior mediastinal nodes, suboccipital nodes, retropharyngeal nodes, parapharyngeal nodes, buccinator, preauricular, periparotid, and intraparotid lymph nodes. So indications of node dissections are if there are clinically node positive necks, then a modified radical neck dissection is performed. In clinically node negative necks, there is a risk of occult metastasis in more than 20%, especially in oral and pharyngeal tumors, and hence SND is performed with frozen section of level 1B and 2A. If positive, then MRND is performed. So the types of neck dissections include radical neck dissections, which is removal of levels 1 to 5 with internal jugular vein, sternocleidomastoid muscle, and spinal accessory nerve. Modified neck dissection is a functional dissection which also removes levels 1 to 5, but one or more of the above 3 structures is preserved. Selective neck dissection is when one or more groups of these nodes are removed, like a supra-omohyoid neck dissection would include level 1, 2, 3 with or without level 4. Lateral neck dissections would be from level 2 to 4. Posterolateral will be from 2 to 5, and anterior neck dissection, which is done in thyroid tumors, will be level 6, which is central compartment. For neck node grossing, when the level of the nodes are sent separately, we need to gross them separately. If they are not sent separately, then we separate the level 1B node from the specimen by using salivary gland that is submandibular gland as an anatomical landmark, and then submit all the levels together. Each node is separated from the fat, and all of them are counted and submitted. In case of larger nodes, if they are grossly metastatic, then one half may be submitted. If they are grossly negative, then both the halves need to be submitted. Smaller nodes can be submitted entirely. So in histology reporting, we need to write the number of nodes identified on each level, which are identified on microscopy, the total number of nodes showing metastasis at each level, the size of the metastatic deposit. In addition, we need to mention whether there is extranodal extension present or absent. This is a predictor of regional recurrence. If there is no extranodal extension, it is ENE negative. In case of ENE positive nodes, it is an optional data element to include whether the extranodal extension is more than or equal to 2 mm, which is known as ENE minor, or ENE major more than 2 mm of extranodal extension. So a little bit about extranodal extension. It is also known as extracapsular spread or perinodal extension. It is defined as extension of metastatic carcinoma from within the lymph node through the fibrous capsule into the surrounding connective tissue, and regardless of absence of stromal reaction. So we will see an example of that, but before that, it excludes any metastatic carcinoma that just stretches the capsule but does not breach it. So to call any node as extranodal extension positive, the capsule of the node has to be breached and it has to go into the adjacent soft tissue. If there is any doubt or ambiguity about ENE, firstly, we can do serial deep sections. And if there is any doubt, a lower category is assigned, that is ENE negative. A soft tissue tumor deposit in lymphatic drainage area is recorded as a positive lymph node with extranodal extension. The extent of ENE is measured as the maximum distance in millimeters from outer aspect of intact or reconstructed nodal capsule to the farthest point of extranodal extension. So just an example of that. So this is a lymph node capsule and the tumor has breached it. So the extranodal extension will be counted from this point up to the farthest point of the tumor deposit. Like this. This node is almost completely replaced by the tumor, but there is no extranodal extension. Another node, a small nodal deposit, but tumor deposit, but no extranodal extension. We can see this intact capsule at the periphery. So clinical significance of ENE is it entails poor prognosis. It is a predictor of local regional recurrence and distant metastasis. And in presence of ENE, adjuvant therapy is given. So in cases of positive lymph nodes, radiotherapy is given. If there is extranodal extension that is present in these positive nodes, then chemoradiotherapy is given as adjuvant therapy. So my take-home message is synoptic data and standard data sets are essential for comprehensive pathology report. It helps pathologists and residents to issue a complete report, including all relevant information. It also ensures that all information is conveyed to the treating physician, which is essential for prognosis and treatment decision. But for all of this to happen in an accurate way, grossing is of utmost importance. So we need to pay attention to the grossing. In case of any discrepancy, we need to have a relook at the specimen, gross specimen, and we need to take more sections whenever required. Thank you.
Thank you, ma'am. Ma'am, there is few questions in chat box.
Yes, sure.
One is, if the tumor is on the lateral border of
Can I just thank,
Yes, ma'am.
yeah, 1 minute. Nishi, can I just thank,
Yes, ma'am.
Katha? Yeah, for doing an excellent job, Katha. Within an hour, you have managed to deal very comprehensively with a very complex problem, albeit that much of what you have talked about is on squamous carcinoma, which is the major problem in our country. Okay. I just want to, reassure all the audience that have been listening to this that a lot of the specimens that Tata Hospital gets is unlikely to appear on your grossing table. Okay, you are not going to see all these very fancy things like uh, mar- marginal mandibulectomies and so many different kinds of maxillectomies, etc. Because this is done by head and neck surgical oncologists in a setting where they have all the infrastructure, etc., and they get a huge number of cases. So don't get worried that you may not be able to identify all the different kinds of laryngectomies and maxillectomies and all the rest of whatever you get in the head and neck. The most common specimens that you will encounter is a buccal mucosa wide excision. You will get a hemilaryngectomy or a hemi glossectomy, a partial glossectomy, and of course, many of our tumors are in the gingival-buccal sulcus, so you will get one form or the other of a segmental mandibulectomy, or you might get a hemimandibulectomy. So don't worry too much about whatever. But what I will tell all of you that nobody actually has any business to be grossing any specimen, whether it is in the head and neck or in the breast or in any other site in the body, unless you know the anatomy of what it is that you are grossing. Okay, so you just don't get a specimen and immediately start describing and putting your knife to it. And if this is true of all specimens, it is really very, very true of the head and neck. And I'm sure Katha will agree with me that unless you know the anatomy of the head and neck, you will not know, what margins to take, because you have to be able to mentally orient yourself to what is just a flat lump of meat on your specimen or grossing table. So just do that. If you are going to work in an institute which has a lot of head and neck work, then you just must orient yourself by getting your anatomy straight. Okay, so I think with that, maybe Nishi, you want to take all the questions that are in the chat box, please. I think I answered two questions of somebody called SR. Okay, SR's question was, if lymph node is positive, do we label WPOI, that means worst pattern of invasion, as 5? And the answer is no. The lymph node is not part of the soft tissue, so that's what I answered. I'm sure you agree with me, Katha.
Yes, ma'am.
Yes, and the other one by SR, if LVI is not identified but lymph nodes are positive, then do we say LVI is present? And the answer is no. You have to actually see tumor inside lymphatics. Okay, so those two I've answered, but please, Nishi, go ahead and ask the other questions.
Ma'am,
Yes.
someone has asked if the tumor is on the lateral border of tongue, how
Mm-hmm.
to measure the depth of invasion grossly?
Um, so if the tumor is, can I go back to my presentation for a second?
Yes, sure.
1 second. Huh? Yeah, so I'll just show. So this tumor, can you see my screen?
Yes, ma'am.
Okay, so when the tumor is present, this is a lateral border of tongue. So this tumor is on the left lateral border of tongue. Okay, and this is, like I said, the anterior part, the medial aspect, the lateral mucosal margin, and the posterior margin. So once you measure the dimensions of 2 dimensions on the specimen which is intact, then you serially slice it from anteriorly to posteriorly like this. And then you measure the tumor from this aspect to the medial soft tissue. So that will be the 3rd dimension of the tumor on gross. Uh,
You know what, Katha?
yeah.
What you need to do is maybe you can
Yeah.
ask for annotation and then draw the lateral, you know, how a tumor appears on the lateral border of the tongue.
Okay, okay, I can do that. Yeah.
Yeah, do that and then show them what. Yeah, Lalit.
So how do I get annotations?
First, make it full screen, ma'am,
Yes, yes, yes.
and annotate there. Right click on the screen.
Yeah, and
There is
this.
laser pointer. Otherwise, you take a
Yeah.
pen.
So the tumor is serially sliced like this. Okay. Uh, Keeping a thickness of 0.5 centimeters to 1 centimeter, mostly 0.5 centimeter. And once you slice your tumor like this, you will have cut sections which are like this. So this is your tumor here, which is extending maybe like this. So this will be your 3rd dimension. And this is the distance from the tumor up to the base. So is it clear?
Ma'am, they wanted to know the depth of invasion grossly.
So on gross, we can't measure the depth of invasion. We can give the thickness of the tumor. So the depth of invasion is given on microscopy. So it will be from the basement membrane of the adjacent mucosa up to the deepest point. So the thickness of the tumor can be measured on gross.
Okay, ma'am. Ma'am, someone has again requested for the same thing, depth of invasion microscopically. Microscopically.
Okay, so I can just. So if you can see here, this is the adjacent mucosa here, and from the basement membrane you draw a line parallel.
Ma'am, you have to share your PPT again.
Okay, I'm sorry.
I think it's.
Is it visible now? Yeah. It's visible right now.
Ma'am, I think you have shared, but still.
Um,
Now it's visible, ma'am. It's
Okay.
visible.
So this is a section of the tumor, and you can see normal mucosa here. So you have to draw a line from this basement membrane of this normal mucosa, and then a line perpendicular from that to the lowermost part of the tumor. So this is going to be your depth of invasion. So for proliferative tumors, the depth of invasion will be less than your thickness. So from here till that deepest point is your thickness. And from this point to the deepest point is your depth of invasion. So for TNM staging purposes, the depth of invasion is important and not the thickness.
Okay.
I just say. Unmuted.
So there is one question where I
One
think.
second, Katha.
Yes, yes,
I'm
sorry.
telling you what their problem is.
Ah.
Okay, their problem is that the lateral border of the tongue has a curved surface.
Okay.
So if you can draw using your thing a hemiglossectomy with a curved lateral surface, okay, and draw a
Okay.
tumor which is not on this, it's towards one surface. So do that because that is the, I understand what is the What's the problem? I don't think I can get annotation unless somebody gives it to me.
Okay, 1 second. I'll try to.
Just draw, a hemiglossectomy. You had a hemiglossectomy somewhere.
Yes, yes,
Yeah,
yes.
so just show that hemiglossectomy on gross.
So
You had a
this
picture.
was, so this is the hemiglossectomy.
No, this is not. This is not a hemiglossectomy as
Okay,
they
yeah.
imagine it. Just go to your pictures of
Yes,
hemiglossectomy, Katha.
yes, ma'am.
No, this is not it. No.
No,
You have a hemiglossectomy and where you were talking about margins.
yes, I have that, ma'am. Just a second. Yeah. Here, this one?
Yeah, now here. All right, you just draw the tumor over here. See, this is not where the tumor is on the surface, right? The tumor is at this lateral border. So draw the tumor on that, Katha.
Yeah. So this is probably the tumor.
Exactly where the tumor is. Okay. So when you stand this on the base, please mark the base, Katha, over here.
This is the base. Sorry, this part.
No, just draw that median, Rafi. There is the base. So if you stand this hemiglossectomy on the base, it's from the lateral border towards the base where you measure
Yes.
the thickness. Because when you flatten it out, people don't understand how you are measuring this. Okay.
Yes.
So I don't know who was asking that question. I think it was before SR. So
Yes, ma'am.
Lakyavi.
Yes, ma'am.
Lakyavi, now, Lakyavi, please write in the chat box if you have understood how you measure on gross or on microscopy, you have to measure it from the lateral border towards the base. And the base is that median raphe,
Yes.
okay, which is present there in the hemiglossectomy, which has been shown by that red line. That is what I think Lakyavi's problem was. Is that right, Lakyavi? Please write in the chat box whether that was your problem. Lakyavi is not written it. I don't know why. Okay, anyway, it doesn't matter. So, what are the next other questions, please, Nishi?
Yes, ma'am. Ma'am, someone has requested to show the involvement of pedineural and pedivascular involvement.
Okay. 1 second. Let me. Mhm. So perineural involvement is involvement of the perineurium of the nerve. So tumor encasing the nerve, involving the perineurium. Here it is. And it is not perivascular involvement, it is lymphovascular emboli. That is a embolus within the vessel. So this, the one on the top left is perineural invasion. You can see this tumor encasing the nerve. You can see these squamous pearls, keratin pearls. And the one on the lower right is the lymphovascular embolus. So this has some RBCs. So this is a vessel showing some wall of the vessel. So endothelial line space showing an embolus.
Ma'am, someone has asked if tumor is very large and not able to give the normal and tumorous section on the same section, how to measure the depth of invasion.
Okay, so it's a very valid doubt. I'll just do some annotation and just show you. So if suppose this is the buccal mucosa and this is the tumor, okay? Some tumor like this, okay? And maybe if it is involving the skin here. So you can't give such a big tumor. So you can take a slice of the tumor and you can divide it into 4 parts and submit it as such. So when you give a grid, you need to draw a diagram on your grossing paper that you are submitting one entire tumor slice as grid. And then you give section numbers accordingly. So 1, 2. So you write this is showing the maximum tumor thickness and with the some adjacent skin, and here will be some adjacent mucosa, and another section 3, 4. So you can
Yeah,
draw.
I just want to say something that it doesn't matter when you have a large tumor. You should have heard carefully what Katha said, because Katha said that it is valid only for T1 and T2 tumors. Nobody really bothers to measure tumor depth or thickness in large tumors. Okay, so in large tumors, the volume is so large that it does not really change much the prognosis. But when you have small tumors, which are T1 and T2 on surface size, then yes, it makes a difference because the thickness, or as is being recommended, the depth, gives you the third dimension of the tumor. Okay, so this question does not really apply to large tumors, let alone very large tumors. Okay, so it's T1 and T2.
Yes.
Ma'am, next question is how do we identify masseter muscle as masseter space involved in T4?
Masticator space is involved in T4, and that is more of a clinical radiological impression. We cannot identify that. We cannot identify different muscles. So usually in T4B tumors, they will give chemotherapy before they operate the surgeon. If the response is good enough, then they will operate post NACT or they go into palliative therapy.
If you have the pterygoid space or the masseter space or masseter muscle involved, these patients have difficulty in opening their mouth. Okay, so that's a very they have this trismus. So then clinically they know that this is involved. The only time where trismus cannot be taken as involvement of a space is if the patient has got very severe submucous fibrosis, because by virtue of the submucous fibrosis, the patient can't open his mouth. It's not by virtue of the tumor that is in the submucous fibrosis. So in these cases, I think imaging helps you to say how deep, or whether the pterygoid muscles, because you get trismus not because the masseter is involved. Yeah, the masseter is, but not very often involved. It's because the pterygoid muscles are involved in anything that is posterior, whether it is in the maxilla or, for that matter, in the retromolar trigone. So that's the situation, and Katha is right. They know this before they actually take it out, and they give preoperative, whatever, adjuvant therapy, maybe chemoradiotherapy, and then operate. Okay, so the only time that trismus does not mean anything clinically is when the patient has submucous fibrosis. Yeah?
Yes.
Okay, ma'am. Ma'am, next question is how is the lateral border is a margin while the surgeon has not cut through it?
Lateral border, do you mean the tongue or the alveolus? So in the tongue, the lateral border of the tongue will be where the floor of mouth is. Okay, so that will be a margin. And on the hemimandibular,
No. On the tongue, it's not floor of mouth. Medial is the floor of the mouth.
anterior and the lateral, ma'am. Gingivolingual sulcus.
So that is a
Gingivolingual sulcus.
gingivo, yeah, sure. Yes, it is it is the floor of the mouth. Yes,
Yeah.
I thought they were talking about the lateral border in the buccal, gingivobuccal sulcus.
So gingivobuccal sulcus, there won't be a lateral border. There will be lateral soft tissue margin. If the skin is not removed, the lateral soft tissue margin will be the lateral margin. There won't be a mucosal lateral margin. Okay.
No, but there is what is called, there is a mucosal margin which is superolateral. No?
Yes, ma'am.
Yeah,
Yes.
because again, you think in your head, okay, you've got a medial gutter and you have a lateral gutter. If you have if you take the mandible as the, as the bone, on which side you have two gutters. On the medial side, as Katha said, there is the gingivolingual. Okay, and on the lateral side, there is the gingivobuccal. So if you think about it, what is a gutter? The gutter actually goes down and up. So there won't be a lateral margin on the lateral side. There is a superolateral margin because that gutter then moves upwards, no? So that's what but that's why I'm saying, please don't imagine these things unless you have your anatomy absolutely straight, that you can measure, you can actually think about this in your head and see what the possible or probable margins are that, and this is a common specimen, okay? Tongue or gingival sulcus with some mandibulectomy along with it. Okay, Lakshyavi has answered, has got it. She said yes.
Now she is satisfied, ma'am. Ma'am, last question is, to call it PNI, what should be encasing circumference?
More than 3/4 of the nerve. I don't know, ma'am. Correct me if.
No. Any PNI is bad. Okay, because it's gone into the perineural space.
Okay.
And once it is entered into the perineural space, then that perineural space allows it to spread. It's a potential space. If you really go to look at a perineural space, there isn't any such thing. It's a potential space between, the perineurium and
No.
the soft tissue that is around it. So if it has got in there, then it is going to make that its way up the nerve or down the nerve, whichever the case is, and that is bad. So when somebody has done a dissection, and you have something either in the lymphatics or in the blood vessels or in the perineural space, what does it mean? It means that your surgery cannot have encompassed this lesion. Okay, that is all that it means, and that is why you have to do something adjuvant, because you see, you identify the disease in the perineural space, but you don't know how far up or down it has gone, and it may not have been encompassed within the surgical margins. Okay, so it is the equivalent of not knowing what your margins are. Your margins may be perfectly clear, and you've done that. Your surgical margins are soft tissue and mucosal margins. But if you have perineural invasion, you cannot rely on that negativity of your margins, because the tumor may have traveled up or down that nerve. Okay, so that's the reason why you need to get adjuvant treatment. Usually radiation therapy, but chemotherapy as well as dictated by the rest of the PT stage. So SR is being listening very carefully to your
Yes,
lecture.
ma'am.
I can see Katha.
Yes,
SR is asking a lot of questions. That's good.
I'm glad.
Very good. But I must thank you, Katha, because you've done a very good job with all your illustrations and your nice pictures that are nowadays we can take because we have the
Yes.
slide scanners.
Yes.
Yeah. So all of this has really made this, I think, a very illuminating experience for the students. And I'm sure there were lots of very, see the claps that are coming up on the left-hand side, and a lot of thank yous, and it was a very great session and all that. So I think you should take a bow, Katha. I certainly think that you've managed to perform this enormous feat in the time that was allotted to you.
Yes,
Yeah.
ma'am. Thanks a lot, ma'am.
Thank you.
I tried to cover the
Oh,
common.
you did a very good job, Katha. And now they will have time to think. And those of the audience that is